All right, welcome to the podcast on ankle disorders. In this podcast, we're going to talk about ankle and foot disorders. All right, first let's talk about ankle joint hypomobility and the non-operative management of hypomobility. So some of the common causes are rheumatoid arthritis, degenerative joint disease, joint trauma, post-immobilization stiffness, and gout. So many of the common pathologies in the foot and ankle are similar to the common pathologies in the knee, hip, shoulder, all the other joints. With rheumatoid arthritis, you'll see RA affect the forefoot early and then progress towards the hind foot and ankle as the disease process progresses. Also with rheumatoid arthritis, you'll notice you'll see tendon ruptures from chronic inflammation. Those who have degenerative joint disease typically get it from post-traumatic arthritis. So they've had some type of trauma, such as a chronic sprains, instability, maybe a fracture that affected the joint. And that accounts for about 70 to 80% of all degenerative joint diseases of the ankle. Also, individuals who have been immobilized will get significant stiffness, as they would with any joint. Individuals who have gout have hypomobility. Now, gout is an inflammatory arthritis that is present due to elevated levels of uric acid. The high levels of uric acid crystallize and deposit within the joints and tendons and the surrounding tissues within a joint. It is most common in the MTP joint of the great toe, and it will cause pain especially with great toe extension. So during that terminal stance, so when you're at the end of stance, your big toe has to extend significantly, and that will cause a lot of pain. All right, what are some common impairments that are noted? Obviously, with joint hypomobility, you're going to notice lack of motion, and this can be at the proximal or distal tibiofibular joints, the talocrural joint, the subtalar joint, the MTP joint, or any of the tarsal joints. You will also notice some alignment deformities, and these could be due to muscle imbalance, tendon ruptures, faulty footwear, trauma, or heredity. Muscle weakness is common, especially in muscles related to postural control. You will have decreased muscular endurance, impaired balance, increased incidence of falls, painful weight bearing, gait deviations, and decreased ambulation. Decreased ambulation can be because of some of the other impairments above. So if someone has impaired balance, they may not be walking as long or as far. Same thing if they are having frequent falls, they may be fearful of ambulating. All right, so you have a patient who has joint hypomobility. What are you going to do for exercise prescription? So educating the patient on a home exercise program, how to decrease joint stiffness and protect the joint. Protecting the joint may involve use of an assistive device. They may also need to modify their activity. You want the individual to remain active, but perform activities at a safe level. And they should be performing range of motion exercises as they are able to within their pain tolerance. You want to try to decrease pain using manual therapy techniques, and this can be grade 1 and 2 mobilizations or other manual therapy techniques to decrease pain. And maybe get orthotics to help alleviate some of the structural abnormalities that are present. You want to maintain joint and soft tissue mobility and muscle integrity. So begin with passive range of motion, active assistive range of motion, progressing to active range of motion. If they have active range of motion, work on isometrics and strengthening as needed. this would be a good patient to work exercises in an aquatic setting to decrease the amount of weight bearing on the extremity, but still be able to do closed chain exercises. Right, as this patient progresses into the next phase, the controlled motion and return to function phases, you want to continue to increase joint play and accessory motion with more joint mobilization techniques. You may be able to progress to a grade 3 and 4 joint mobilization and increase stretching of that joint. You may be able to perform mobilization with movement into dorsiflexion for a talocrural joint, and also work the MTP joint. Realize that the patient needs at least 60 degrees of big toe extension at that MTP joint for normal gait. You want to continue also to work normal strengthening to ensure that they regain their balance, work proprioceptive exercises, and develop cardiopulmonary fitness. The foot and ankle joint is important in closed chain activities and important in the proprioceptive role and balance. It does also work in an open chain and balance in gait. So during the gait cycle, about 40% of the time one of your feet is off the ground working in an open kinetic chain, but about 60% of the time that foot is on the ground. So you have a point in time when both feet are on the ground, but you need to lift the foot up and clear it. So working both open and closed kinetic chain exercises are important. With that being said, the majority of the time that patients have ankle and foot problems, it is with the foot on the ground. So not 100% of the time, but most of the time you need to work patients who have ankle problems in a closed kinetic chain. All right, what kind of ankle surgeries can be done for individuals who have advanced osteoarthritis or rheumatoid arthritis of the ankle? Right now there are two main types of surgeries: a total ankle arthroplasty or ankle replacement, or an ankle arthrodesis. And so we're going to talk about the total ankle arthroplasty or the ankle replacement first. All right, who should get a total ankle replacement? So individuals who have a low or moderate physical demand. If you want to return to running or a very high physical demand, the ankle total replacement may not be the appropriate surgery for you. If there is if you have sufficient ankle ligament stability, that's an indication for surgery. You also need to have adequate vascularization to allow for wound healing following surgery. Contraindications include ankle infection, poor bone conditions such as osteoporosis, avascular necrosis of the talus, and peripheral neuropathy with decreased sensation or paralysis of the lower extremity. Additionally, individuals who've had long-term corticosteroid use will also be contraindicated, and this is due to that poor bone stock. So the implant consists of two pieces of metal, one fixed to the tibia, one fixed to the dome of the talus, and then a polyethylene surface between them that acts, I would say, similar to what a meniscus would seem like. In order to get to that surface, the surgeon goes in anteriorly between the anterior tibialis and the extensor hallucis tendon, and debrides the bone down and inserts the implant anteriorly. Complications can include fracture of the medial or lateral malleoli, both during surgery and after, infection, tarsal tunnel syndrome, and complex regional pain syndrome. Complication rates are higher in those who are obese, those who have diabetes, and those who use tobacco. All right, what do we do post-operatively for individuals who've had a total ankle replacement? Unfortunately, there are very few published guidelines to guide us. Um, the recommendations vary a lot for how much to weight bear, when to begin range of motion following surgery. So the recommendations they put out in the book were summarized based on some experience of the authors. It is something that we definitely need more research on. The authors recommend immobilization for 10 to 21 days, so for up to 3 weeks, immobilization in a splint following surgery. Additionally, non-weight bearing for 3 to 6 weeks following surgery. During those first 6 weeks, the goal of PT would be to gain functional mobility, so make sure the patient can ambulate with the assistive device, and to control edema and prevent infection in the incision. You can minimize the atrophy of the foot and ankle muscles by doing low intensity isometric muscle setting exercises. And you can do active range of motion of the toes. Once the patient moves into the moderate and minimum protection phases, the immobilizer is removed and progressive weight bearing is then allowed. The goals of the moderate and minimal protection phase is to achieve 100% of the range of motion pain-free, and to begin to restore the strength, muscular endurance, and balance in the lower extremity. You also want to work to improve aerobic capacity and resume safe work and recreational activities. It is suggested that all patients can do activities such as biking, light impact aerobics, elliptical, stair climber. If a patient was doing these kind of activities before, such as hiking or skiing or mountain biking, they are able to resume that after. But if a patient, even if they were doing these activities before, such as soccer or high impact aerobics, jogging, snowboarding, water skiing, those are not recommended following a total ankle replacement. So those higher level and higher impact activities that may require cutting or more ankle stress are not recommended after surgery. All right, what are the outcomes for total ankle replacements? Well, they are not as good as some of the other joint replacements we have. Historically, about 90% of the total ankle replacements are surviving 10 years. 90% are surviving 5 years, about 75% are surviving 10 years. And not that the patients are dying, it's that the ankle replacements need to be redone, okay? So realize I'm talking about the prosthetic survival rate, all right? But with that, there is technological advances. So hopefully the ones they're doing now are better than the ones they did 10 years ago. And when it comes to returning to physical activity following a total ankle arthroplasty, studies are varied. There are a few studies that show an increase in physical activity following a total ankle replacement, and there's some studies that are showing no significant change in their participant group. All right, the next operative procedure for hypomobility is an arthrodesis, which is a fusion. This may sound crazy. This patient doesn't have movement in the foot, so what are we going to do to treat it surgically? We're going to fuse it. The reason they do this often is because movement is painful, and so if you fuse a joint, then you're preventing that painful movement. So why do patients get this? They have it because they have debilitating pain. They either have instability or they have stiffness in their joints. They may have a deformity that's causing some malalignment, or they may have a congenital abnormality. They may also have osteonecrosis of the talus. This also can be done if a total ankle replacement fails. Who shouldn't get this surgery? Those who have vascular problems or an infection in their limb should not be having this surgery. Common areas of arthrodesis include the ankle, which fuses the talus to the tibia, the hindfoot, which can include fusion of the talonavicular joint, the calcaneonavicular joint, or what they call a triple fusion, which is the talocalcaneal, talonavicular, and calcaneocuboid. They can do a arthrodesis of the first toe, and when they do that, they typically fuse it into about 15 to 30 degrees of big toe extension to allow a little bit more normal gait pattern. So when the patient is standing, their toe may not be in contact with the ground, but it does allow at that terminal stance, so at the end of standing, a little bit more normal gait. And then the IP joints of the toes can also be fused. How do we manage these patients post-operatively? They will be immobilized for 6 weeks or so to allow healing of that fusion. They will also be non-weight bearing. So instructing them on ambulation non-weight bearing, either with crutches or with a walker. These patients also will benefit from either being in a wheelchair or being on a knee scooter to allow non-weight bearing of that limb. Post-operative exercises, they can perform exercises not related to the joint that was fused. So if it was an ankle joint, they can do toe range of motion or they can do knee range of motion, but you shouldn't be trying to get range of motion in a joint that they are fusing. With most of these individuals, they can return to physical activities. They may have to shift from a higher impact to a lower impact sport or activity. So they can return to things such as cycling, swimming, walking, but more high impact activities may be difficult for them. For short-term outcomes, the patients face difficulty walking on uneven surfaces, walking on inclines, and ascending and descending stairs. Individuals long-term, though, tend to get degenerative changes at the joints proximal and distal to the joints that are fused. So remember, our body still wants to move, and that foot needs movement. And if you fuse one joint or one area of the foot, the joints adjoining that are going to have to compensate for that lack of movement. And so they found that over time, long term, there's a higher rate of degeneration in the accompanying joints. All right, another common foot problem is plantar fasciitis. This is pain along that fascia on the bottom of the foot. Pain is very typical on the medial tubercle of the calcaneus, and it's very tender to palpation. Predisposing factors include a high BMI, an inappropriate footwear, or a high or low arch. All right, another source of heel pain can be from areas around the calcaneus. So it can be pain on either the plantar or superior surface of the calcaneus. This could be from heel spurs or tissue bruising from jumping. So if it's on the plantar surface of the calcaneus, it's probably from tissue bruising. You can have a heel spur on the plantar or the superior surface of the calcaneus. If there's pain on the superior surface where the Achilles inserts, it could be from tendinopathy or from the Achilles bursa. All right, another non-operative foot pain pathology is shin splints. Shin splints are used to describe pain that is along the posterior medial or anterior lateral aspect of the leg usually in the proximal 2/3 of the tibia. And they can be broken up into anterior and posterior shin splints. Anterior shin splints are caused by overuse of the anterior tibialis muscle, and it's associated with hypomobile or tight gastrocsoleus complex, a weak anterior tibialis, and excessive pronation. And these individuals have pain that increase with dorsiflexion. Where posterior shin splints also have a tight gastrocsoleus complex, but a weak and inflamed posterior tibialis, and these patients have increased foot pronation. Their pain is increased when the foot is passively pronated, kind of beyond what their current level is, or when they try to actively supinate the foot. All right, so what do we do to treat these foot pain problems? So in that protection phase, cross-friction massage may be needed, especially with the plantar fasciitis. Submaximal muscle setting exercises, passive stretching to the plantar flexors, they are often tight, active range of motion in that pain-free range, activity modification. So any activities that are high impact or causing pain need to be eliminated, and orthotic prescription. If a patient's foot mechanics or foot postures are abnormal, we may need to prescribe orthotics. There are some taping procedures that can be done to help with foot postures that you can learn, but orthotics may be needed. Once the patient moves into the controlled movement and return to function phase, make sure that you're correcting any strength imbalances, looking all the way up the kinetic chains, and not just within the foot and lower leg, but the knee and hip and even core if needed. Improve flexibility and correct lower extremity alignment, realizing that some of the alignment issues may come from hip weakness as well as knee and foot problems. All right, what is the treatment for so another foot problem is ankle ligamentous injuries. We know from previous chapters that they can be of various grades, and you need to take that into consideration with treatment and your management of it. But how do we treat these? So in the protection phase, Rice principles need to be applied. Controlling the edema is very important, and if it is a significant sprain, you need to provide external support so that there is not continued stress on that area. Active range of motion can be performed in this phase, realizing that the patient will self-limit when performing active range of motion and minimal damage will occur. Protect the joint. This can involve using assistive devices to limit weight bearing, and submaximal isometrics can be performed. The controlled motion phase is where you can begin to integrate progressive weight bearing and normalize the gait. You also want to normalize joint movement, so you can work to perform gentle stretches or subtalar joint mobilizations, especially in that sagittal plane. You don't want to perform joint mobilizations that will stress the joint or the ligament that was torn. Non-weight bearing exercises and seated exercises, progressing to weight bearing as able. A grade 1 strain will progress to weight bearing exercises much faster than a grade 3 strain will. During the return to function phase, you need to emphasize balance, coordination, and stability. Ankle sprains occur in a weight-bearing position. The loss of proprioception and the loss of quick speed reaction time is what has caused the ankle sprain to start with. So making sure they can regain that is important. Begin to utilize unstable surfaces such as a Bosu or the blue foam, BAPS board, a mini tramp. Incorporate forward, backward, and crossover movements, not just straight front and back plane movements. and progress to sports activities, jumping, hopping, plyometrics. Make sure that you're getting the patient back to the activities that they need to be able to do. Individuals who have chronic ankle instability with chronic ankle sprains may need ligament repair with surgery. Indications for surgery are those chronic tears. These individuals had to have failed conservative management with physical therapy. So there's two types of repair procedures. One is a direct repair where they can repair either the mid-substance or re-anchor an avulsed an avulsed ligament to the bone. Reconstruction with augmentation occurs when they reconstruct the ligament and then augment it with either an autograft or an allograft. A surgical approach for this has historically been through an open approach. There are some newer surgical approaches that are being done arthroscopically, but the vast majority that you will see will be through an open incision laterally. The graft is fixated with bone tunnels drilled through the fibula and the calcaneus for the anterior talofibular, for the calcaneofibular ligament, and fixated with bone graft. All right, what does rehab look like after ankle reconstruction surgery? So these patients will typically be casted for a few weeks and then into a removable boot. Depending on the stability or the severity of the surgery, the boot may be worn for up to 12 weeks, anywhere between 6 and 12 weeks. Typically, these patients will be non-weight bearing and then progressed up to full weight bearing. And again, that full weight bearing may be allowed as early as 6 weeks or may take as many as 12 weeks to progressively get to full weight bearing. During this phase, isometrics are a good idea, and you also want to maintain the strength of all non-involved muscles. As with any other post-surgical management, you want to do what you can to decrease the chance of a DVT. Now, this patient has their ankle immobilized, so ankle pumps are not something they would be able to do. But you can do other exercises to help with blood flow. You would work on gait training, elevation of their leg, decreasing their edema. In the moderate and minimum protection phase, you want to restore pain-free range of motion, increase the strength of their ankle, foot, and entire lower extremity, normalize gait, regain neuromuscular control, balance, stability, and agility. So when a patient hasn't had their foot on the ground for that long, they're going to lose a lot of balance, a lot of neuromuscular control. Their mechanics will be altered when they try to do anything as simple as a squat. And when they start returning to more dynamic activities, their form will be altered. And make sure they have a safe return to functional activities. All right, surgical repair of a ruptured Achilles tendon. If a patient ever comes to you and says they ruptured their Achilles, usually it's a pretty traumatic injury. I've had patients say they thought that somebody had shot them. They heard a pop and they turned around and looked to see who shot them in their leg. So it can be a loud pop and it can be pretty painful. All right, who should get a repair of their Achilles tendon? Obviously somebody who's torn it. They can be treated conservatively, so splinting, especially if a patient has end-to-end opposition of their Achilles, they can be treated conservatively. But if they cannot get that end-to-end opposition, they need to have surgery. And if this individual wishes to return to a high demand activity, they should opt for the surgical procedure. All right, there's two types of procedures. One is a primary repair, where they go in the posterior aspect, just along the Achilles tendon. They are able to oppose the torn ends and suture them together. In a delayed repair or reconstruction, they harvest a graft, most often the fibularis brevis, and use that to assist in the reconstruction. All right, what are some complications that can occur with a Achilles tendon repair? The tendon can re-rupture or fail. Wound complications can occur, such as an infection or delayed healing. You can get heterotropic scarring, a DVT, restricted ankle range of motion, especially into dorsiflexion, limited strength and muscular deficits, especially with those plantar flexors, and you can get complex regional pain syndrome or RSD, which is rare, but it can happen. What does rehab look like after an Achilles tendon repair? These patients will come in, they may be casted for a week or so, but most often they're in a boot that allows for a change in ankle range of motion. So they will be typically allowed weight bearing as tolerated within the first 2 weeks, progressively increasing weight bearing within the first to full weight bearing in the first 6 to 8 weeks. That orthosis or that boot needs to remain when in weight bearing for those first 6 to 8 weeks. Additionally, these patients will be allowed to weight bear, but in a plantar flexed position initially. So either they'll be in a boot that keeps them in maybe 15 to 20 degrees of plantar flexion initially, or the boot will allow for a heel lift to put the patient in 20 degrees of plantar flexion when weight bearing. After the first 2 to 4 weeks, then you can decrease to where the patient is at 10 degrees of plantar flexion during weight bearing. So you either remove a heel raise or heel lift, or you adjust the boot to allow a little bit more movement towards dorsiflexion. By 4 to 6 weeks, you can progress the patient to being in a neutral position. So you want to put that Achilles on slack, in other words, to allow healing, and then progressively move them into where the Achilles is in a little bit of stretch. During the maximum protection phase, you can work on muscle setting exercises, active range of motion, where the patient can move but stop themselves if they feel pain. Begin weight-bearing activities to restore muscle balance reactions and maintain cardiopulmonary fitness. This maximum protection phase may not start initially after surgery. It may be delayed by a few weeks to allow healing of that Achilles. For the moderate protection phase, the goal is to increase range of motion and begin to normalize it. Get strength and endurance normalized also, improve balance reactions, and improve proprioception. Reestablish a symmetrical and normal gait pattern, and continue to work on cardiopulmonary endurance. Once the patient is in that minimum protection phase, you can work bilateral to unilateral exercises and begin to do more dynamic exercises, beginning with static and then dynamic and returning to jumping. This maximum protection phase may take up to 6 months, where going back to the moderate protection phase, that can begin at about 6 weeks and progress up to 12 weeks. All right, that is it for the Ankle and Foot podcast. Thank you very much.